moving on now to major symptoms and approaches to treating these symptoms. The first, and what I call kind of the big kahuna, essentially, of symptoms is pain. And it is something that is really crucial as a symptom to address. It's the most common symptom of all. And when looking at cancer and what cancer does, that we see pain as a symptom that occurs both due to the cancer itself, which I'll talk about further, as well as due to the therapies and procedures that clinicians do in order to treat the cancer. And so you can see it's the price someone is paying in order to receive that therapy procedure is dealing with pain as a side effect. So when we think about cancer pain, there's three major types that really have to do with the location of the source of the pain and the experience someone has of that type of pain. So the first is a type that is called somatic pain, which is body-related. This involves the structures of the body, like bone, muscle, skin, joints. It's typically described as aching. So an example within cancer may be a patient who has a bone metastasis, and that is often described as an aching type of pain. A non-cancer related example would be arthritis, but again, describing that aching type of pain. Visceral is the second type of pain, and that is organ related. The term viscera refers to an organ, and so this is often due to involvement of the intestines, for example, or liver or other organs. It's typically described as cramping or aching, but can be very difficult to pinpoint. Patients often describe pain in their intestines really more generalized over their abdomen, and can be a very discomforting sensation in terms of not actually having a particular location to pinpoint. Neuropathic pain is the third type of pain I want to mention here, and it is nerve-related, so involving peripheral nerves or the spinal cord. It's typically described as a shooting pain or electrical in nature. It can often be associated with numbness or weakness, particularly if the nerve itself has some damage. Other descriptors people mention are kind of feeling this pins and needles sensation or shock-like sensation. And then moving on from there, considering a major class of medication that is used for the treatment of pain, opioids. I kind of entitled this The Good, the Bad, and the Ugly. I think opioids offer tremendous benefit for cancer pain because they are therapeutic and effective in all three major types of pain that I've mentioned, somatic, visceral, and neuropathic. They are not the only agents that can be used for pain, but play a primary role. Cancer pain is often complicated, i.e. involving more than one of these three types, and so it is yet another reason that opioids are a good class of pain medications to consider. And then if NSAIDs, i.e. things like ibuprofen and other over-the-counter drugs, and Tylenol are not very effective, opioids are the recommended next step in the treatment for cancer pain, as per the World Health Organization approach to cancer-related pain, and what we typically recommend. Now here's where there's a lot of stigma, and this is kind of the bad and the ugly, around opioids. There's a lot of different names for opioids. People call them narcotics, and that is a term that people think of as kind of altering your sensorium and blunting your senses, and it's a term that people hear with a strong association to crime, with the narc squad, et cetera, that is associated with the police and drugs, and I think that is a huge barrier for accessing this type of therapy for pain. As a result of the misuse and abuse of opioids outside of the context of pain and cancer-related pain, it has created a lot of misperception around the use of opioids and what occurs when one takes opioids. So with regards to opioids, I wanted to go over a very basic approach. This is really getting down to the nitty-gritty of what happens on a day-to-day basis when you're taking pain medications. I think it's also something that we don't tend to do well when people are coming in and out just for clinic visits or an infusion, in terms of trying to go through some of these strategies for managing pain on a day-to-day basis. One approach that is really helpful in guiding pain medication and treatment is keeping a pain diary. And so this does not have to be very complicated, but really just to have some record of when someone's having pain, what medication they take, is it effective, and looking at patterns and how responsive pain is to the interventions that one tries. It can lead to dose changes, scheduling changes with regards to the pain, and this is invaluable as a tool both for patients and caregivers as well as clinicians. I mentioned pre-medication strategies, and you may recall just from your last treatment, chemotherapy, that there were pre-meds or pre-medications that you had to take around the time of the administration of the chemotherapy. It helped maybe prevent some of the nausea, or you got additional fluids to prevent kidney injury, things like that. And that same principle of giving a medication prior to an event or activity can be helpful in preventing a flare of pain. Oftentimes, patients and caregivers can predict, well, I know that if I go out and take a walk or get groceries and hike up the stairs, I'm going to have more pain, and it's going to make my pain flare. So it's reasonable to actually say, I'm going to preempt that by taking my pain medication 20 or 30 minutes prior to going through that activity so that I don't have a big flare of pain. And sometimes by doing so, you can decrease the amount of pain medication you normally would have used to treat that flare. In considering the transition from just short-acting or intermittent pain medications to more long-acting or extended-release pain medications, we want to look at things like a pain diary, at how many times someone needs short-acting pain medications. And when I say short-acting, I think about examples like oxycodone or Percocet or Vicodin. And we think about how that pain pattern may be affected if someone were to start a long-acting medicine that is more even, that gives better control that way. When patients are having continuous pain and are taking the short-acting medications 4, 5, 6 times a day, that's a very good indication that longer-acting extended-release form will offer better control. The last thing I wanted to mention is that in taking pain medications, if one waits until the pain is very, very severe, like a 10 out of 10 before taking the medication, it often takes a higher dose of the medication than if you'd taken something when the pain was milder, more of a 5 or 6 out of 10. And so waiting until the pain gets so severe can often mean that you're having to take a higher dose than you normally would have. So dispelling the myths and legends once you are starting to take medications, the first I wanted to mention is this question of, will I get addicted? And I can tell you, first of all, that I have not yet seen a patient who has cancer who's taking pain medications or opioids for pain get addicted. Addiction is really a very pathological phenomenon that we see when patients exhibit abnormal behavior and a psychological shift in their view of the medication or the substance to the point that they harm themselves and their psychosocial role, say their job or their role in their family, with regards to pursuing that substance. It's a very different scenario than what we see with medications called dependence, where someone's using a medication appropriately for their condition. Think of using steroids or high blood pressure medication, where your body's chemical receptors get accustomed to, dependent on those medications existing there. And then when those medications are stopped abruptly, someone will experience usually withdrawal syndrome, where they have, for example, with steroids, people get very fatigued, they can have other symptoms, and that goes along with what we see with opioids, just like the high blood pressure medications, just like steroids, that people do develop dependence, where it's that chemical phenomena of the body's receptors getting accustomed to that medication being there. That is not the same as addiction. Again, dependence that occurs when patients are on medications for a chronic period. The next question I wanted to address was that whether treating pain and controlling it with medication will mask some sign of a change in the cancer. And this is a concern that I've also not seen occur where something gets masked and missed due to the treatment of pain. What I will say is that when you're taking medication for pain, that you want to monitor if there's new pain or changes in that pain and bring that to the attention of your oncologist so that there's not something that doesn't get addressed, but that could mean that the pain seems to be getting better and you're not needing the pain medications as much. Sometimes that's an indication that the cancer is getting better. But those changes are usually things that you can identify while taking pain medications. The third question that I wanted to address was whether opioids stop working at some point, leading to this conclusion that I shouldn't use those medications because I want to save them for when the pain is worse or very bad. For that myth, I would want to say that it's certainly not the case, and that there's no limit also in terms of the dosing of opioids. So patients can start them and be maintained on a dose for a certain amount of time, and if the pain gets worse, their oncologist can assess them and increase that medication. And there's not a ceiling to dosing opioids for pain. I think that, again, it just underscores the point that there's plenty of good reasons to treat pain and treat it appropriately. So it is not really distracting from patients being able to lead their lives. A brief word on opioid-induced constipation. We know that opioids cause different side effects, and constipation is the one side effect that does not go away, even when a patient's body becomes dependent or accustomed to the medication, the opioid. Part of it is due to the fact that those opioid or pain receptors that exist in the gut, when they are bound with the opioid medication, that causes flowing of the gut and constipation. So a mentor of mine always used to say that the hand that writes the opioid prescription should also write a bowel regimen. So in thinking about the management of keeping the bowels regular and avoiding constipation, I will say that while a lot of the over-the-counter laxatives recommend that you need to talk to a physician before taking these long-term, that basically patients who are on chronic pain medication remain routinely on bowel medications long-term without complications.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support. Thanks again.